Ég rétt rúmlega tvítugur þegar ég greindur og fréttirnar sem ég fæ þá eru að ég sé með þennan skrítnu augnsjúkdóm með skrítnu latínunafni, retinitis pigmentosa, kallar RP, og þá fæ ég þær fréttir að það séu enga meðferði til, engin lækning og það sé í raun og veru ekki von á lækningu eða meðferð á meðan að ég muni lifa. Og ég muni væntanlega verða blindur upp úr 50. Nú ég rúmlega 50, ég reynda greindur lögblindur sem þýðir að ég með minna en 10% sjón sem að lýsir í því að ég með mjög þröngt sjónsvið sem og í kringum 10 gráður, það svona eins og horfi gegnum klósettrúllu og svo sé ég ekkert þegar það fyrir að rökkva eða myrkva.
Reynslan sem Kristinn Halldór Einarsson lýsti rétt í þessu var reynsla margra sem greindust með arfgenga hrörnunarsjúkdóma í sjónheimnu fyrir aðeins fáeinum árum síðan. Þess vegna fengur í því að heyra framförum sem orðið hafa til þess að fólk sem greinist ungt með slíka sjúkdóma gæti horft fram á bjartari tíma. Dr. Gerald sérfræðingur í augnsjúkdómum við Háskólann í Suður Kaliforníu og kom hingað til lands í tilefni alþjóðlegs sjónverndardags 10. október. Þar greindi hann frá fjölda rannsókna og klínískra tilrauna til að finna meðferðir við þessum ólæknandi sjúkdómum og þeim gríðarlegu framförum sem orðið hafa á þessu sviði á síðustu 20 árum.
What I'm here to talk about is in a meeting in a few days is treatments and therapies, hopefully cures, for blindness, for certain forms of blindness, particularly those called inherited retinal degenerations. When I started research heavily in the mid-'80s, I had very little to talk about as far as therapies for inherited blindness, retinal degenerations. Now, I have chosen the topic of going from darkness scientifically, where we knew nothing or very little, to the light of clinical trials, where there are many potential therapies being tested, both in the laboratory and in the hospitals with people, for these types of inherited blindness. So there is great hope that many of these people will have functional vision again in the future.
But you remember the time when people who had diseases that would gradually lead to blindness did not have any solution ahead of them, I mean in front of them.
That's right. Most of these people had no hope. Up to just a few years ago, they were told, go home, get a white cane, get a dog, learn Braille, you will go blind. Sometimes a bit earlier. There are early onset degenerations, sometimes a bit later in adulthood, but you will go blind. Now, with the research that has been done in the world over the last 20 or 30 years, it's coming together in human clinical trials in hospitals to test these basic theories to see if they are both safe and what is called efficacious. Does it work? And many of them are going along very nicely now, such that there are 1 or 2 therapies that are now available, which possibly we can talk about in a few moments, that are now available to the general public. The world's population is aging, which is nice. That means we're all living like me, older, young, healthy, good lives and whatever. It's thought that within the next 20 years or so, with the world's population getting older, the number of age-related macular degeneration, AMD patients, will go skyrocketing. So there will be an explosion in the disease as such if we do not get therapies now to begin treatment to have something for all the older people. Maybe half or a third of the 90 age population will have some vision loss, at least, if not blindness, due to age-related macular degenerations. So you're quite right, this is a major problem.
But how do specialists like yourself categorize diseases?
It's fairly complex. Let's back up and let me say, for starters, that what I'm particularly talking about with age-related macular degeneration, with retinitis pigmentosa, are diseases of what are called the neural retina. The retina is part of the eye, it's in the back of the eye, but it's part of our central nervous system. They're neurons, just like in brain. So the CNS, central nervous system, has two parts, big brain and a little retina, but very similar types of cells. In the retina is a very specialized cell called the photoreceptor cell. The photoreceptor cell's function is to capture light, turn it into an electrical signal, and pass it on to the brain for vision. Fairly simple. It has the highest metabolic rate of any cell in the body, more than a heart cell or a liver cell or anything else. And so it's very susceptible to genetic problems. So the inherited retinal degenerative diseases that we're talking about have a distinct genetic component that all focus in and ultimately cause the death of the photoreceptor cell. And so it's the photoreceptor cell we need to preserve in therapies for all these retinal degenerative diseases we're talking about. Again, the older we get, the more susceptible we are to some of these diseases, such as age-related macular degeneration. There are two major types of photoreceptor cells. One called rod cells, because they're shaped like rods. They look like rods in the electron microscope. The other, cone cells. They're shaped in a cone shape. And in the macular degenerations, it is mainly the cone cells that are affected. Now, I just said that they're mainly clustered in the central part of the retina. So people with macular degeneration, such as AMD, have trouble with central vision. They can see well peripherally from the side of the vision. So I can tell, for example, somebody with AMD because they're looking out of the side of their eye at you because they can't see you directly looking ahead. The other major type of retinal degeneration is called retinitis pigmentosa and allied diseases, some small sub-diseases. And those mainly affect, those genetic defects mainly affect the rod photoreceptor cells. Now, as cones are mainly in the central part of the retina, rods are mainly in the periphery, the side part of the eye. And they serve low vision, dawn, dusk. For example, a rat eye is almost all rods because that's when they function. They go out hunting and foraging at dawn and at dusk. So for retinitis pigmentosa, those people have what is called tunnel vision or shotgun vision because the rods in the periphery of their eye are not functioning properly or dying. So it's just the reverse of the macular degenerations. So an older person with AMD can't see in the central part, they can't do a computer well, they look at their grandchild, they can't see the face of their grandchild as such. Somebody with retinitis pigmentosa, generally their central vision is preserved as if they're looking down a long, thin barrel of a shotgun as such. And so they can see a face well, they can read quite nicely off of a computer, but they have no peripheral vision. So many of them, for example, think that they can drive an automobile. They can't because they have no peripheral vision. They see no cars that are coming at them from a side street or something, even though they can look and they can see the speed, they can look ahead and see the stoplight or something like that. So they're very interesting diseases because they do affect the photoreceptor cell, but the two types of photoreceptor cells function quite differently, leading to very different diseases here. Again, what we're coming to now, after many years of fruitless, well, I won't say fruitless research, of basic research in the laboratory that has now moved to clinic work with humans called clinical trials in hospitals. What we're moving to is testing many basic theories, 6 or 7 different major directions, which I can name, where ultimately we hope that they all lead to some type of therapy for one form or another of retinal degeneration.
This disease, retinitis pigmentosa, is that related to any other diseases that we might know of and are common elsewhere in the body?
Mm-hmm. They are all part of the central nervous system diseases because, again, photoreceptor cells are neurons, just like brain cells are neurons, so they function electrically, just like the brain does as such. So we think that there could be very close connections between things like AMD and Alzheimer's disease. In AMD, what the doctor will see in the AMD eye are little lumps of garbage called drusen that are very obvious if the doctor just looks in with a bright light. And they're garbage dumps very much like the accumulations in Alzheimer's disease. They're different material and all, but the theory is the same, that these garbage heaps, it's like being just covered in garbage, and the photoreceptor will die ultimately because of this. So yes, to answer your question, that many of these retinal degenerative diseases are very similar. They're parallel. They're not the same, of course, but they're very parallel to other forms of central nervous system diseases. And I think the best example is Alzheimer's disease.
Do you have any advice for people who want to preserve their eye vision, and can they do anything differently? Can they lead a specific life or do any exercises for the eye or I don't know what?
Yeah. No, you're right. Let me say, particularly for those with age-related macular degeneration, AMD is what scientists call a complex disease because there are 2 major components that lead you to AMD. One is genetic mutations. So from your grandparents, your parents, or whatever, you have genetic mutations in your body that can lead to AMD. It doesn't mean you're going to get AMD, but it predisposes you to AMD. The risk factor is higher. And interestingly, again, for the population here in Iceland, it's thought that most AMD gene mutations came out of those people who migrated from somewhere in Europe, possibly the Vikings, possibly, who knows else, the Celts or other people. So those genes are much more prevalent. The risk genes in Iceland, Northern Europe, the United States, Australia, and less frequent in China, in Japan, in Africa. So that's the genetic part of it. There's a genetic risk factors because we have inherited mutations from our ancestors. But there's what's called an environmental component too, and I'm getting to actually answer your question now. And that environmental component mainly is oxidation. Now, oxidation is bad for skin, for example, as one gets older. My skin on my face is sagging because the collagen is getting oxidized and it's not as strong and firm as it used to be, so it's starting to sag. So that's one bad problem with aging, with oxidation. Oxidation can also occur because of things like smoking. So what scientists did, and there's one scientist in Amsterdam in particular, who had a huge Rotterdam study, and what they found is that people who smoked had about a 3-fold higher incidence of AMD than those who did not smoke. So smoking, oxidation, is a major effect in AMD. Therefore, stop smoking. And then for older AMD patients, make sure your children and grandchildren don't smoke. About 10 years ago in the United States, the National Eye Institute began a huge clinical trial on the effect of antioxidants on AMD patients. And what they found is that those patients who were on the antioxidants versus without them, a placebo as it's called, as you know, those patients on the antioxidants had about a 25% lower risk of getting AMD than those on with no antioxidants. So the one treatment for AMD now is the use of antioxidants, and they are sold in a certain grouping, a couple of vitamins, zinc, and a few other things like that. So probably here in Iceland, certainly in the United States, I know, many people with the early AMD are taking them, the antioxidants, as the one possible thing that will slow the AMD process down and preserve their vision, maybe for decades, maybe the rest of their life. So only one treatment right now for dry AMD, which is the slow variety where the photoreceptors die.
But this you've been telling me now about the smoking and the antioxidants, is this common knowledge, or
Yes.
it should be common knowledge?
Yes, it is common knowledge. Unfortunately, I think you're probably right. It's not too common knowledge. People would have to know what to look for. For example, on their computer, from their ophthalmologist, from their eye doctor, and frankly, even many eye doctors are general practitioners who don't know that don't have that specific knowledge about AMD. But those of us in the field, this has been well known and documented for 5 years now. The clinical trial is over. It was successful. It showed that this one set of substances, a couple of vitamin E and vitamin C, with zinc, which is an enzyme supplement as such. It revs up enzymes, is quite effective. So yes, it's known, but I don't think it's gone out to the general public yet. What we say in AMD research is that if it's good for your heart, it's good for your eye. So anything that protects your heart, low cholesterol, good vitamins. In most of my lectures, I have one slide that ends with, as your mother told you, eat your vegetables, because they contain many antioxidants. Broccoli and all those good green things that most children hate have excellent antioxidants in. And so what that might do for the younger person is move AMD 10, 20, 30 years, or maybe longer, into the future. And as such, they might not even get AMD. Two things. Number one, good antioxidants, and no smoking is the major thing. The other variety is called wet AMD for macular degeneration. Older patients who have dry AMD, 10 or 20% of them, somehow in those people a switch is turned on and new blood vessels, abnormal, bad, leaky, nasty blood vessels start to grow into the retina and around the retina. They're not normal, so they leak, they hemorrhage, blood starts dripping out, and those people can go from a slow decline in their vision where they'll never get blind with dry AMD, maybe, not even blind, but suddenly in 6 months they are blind because of the hemorrhage, which will kill the photoreceptors in days or a week or two. So there is no preventative treatment that we know of, although the vitamins, antioxidants, seem to slow the process and so push wet AMD off into the future. But what do we have then as a treatment? There are injections now of antibodies, special antibodies that will slow down or stop the growth of these new blood vessels. So as opposed to 10 years ago, where there was no treatment, again, go home, you're going to go blind, 6 months, look at your grandchildren's faces, try to remember your wife's face or something like that. But now, those with wet AMD, there is a treatment available, and I'm sure it's available here.
Til þess að gagnast þeim sem greinast með vota afbrigðið af aldurstengdri augnbotnahörnun þarf helst að hefja meðferð á fyrstu stigum sjúkdómsins. Ef það er ekki gert, getur sjúkdómurinn þróast hratt og leitt til blindu. Þær meðferðir sem hægt að fá hér á landi eru sprautumeðferðir sem vinna gegn nýæðamyndun, en það sú æðamyndun sem leiðir til þess að æðar í augunum springa og sjúklingurinn missir sjónina. Dr. Chater hefur einnig komið að rannsóknum sem tengjast gervisjón, en hún gagnast fólki sem hefur misst sjón vegna hrörnunarsjúkdóma í sjónhimnu. En þá notuð eins konar myndavél sem sendir rafeindaboð inn í sjónhimnuna sem sendir boð til heilans í gegnum sjóntaugina. Við þetta verða til frumstæðar myndir. Slík meðferð enn sem komið afar kostnaðarsöm og ekki í boði hérlendis. Dr. Gerald Chater hefur hins vegar upplifað þegar blindur maður fékk sýn.
Let me give you one example of a success story, one of my 6 good examples now. And that is an electronic prosthetic device, a very small patch, very thin, very flexible, that the eye doctor, the surgeon, will actually insert in and place on the retina. The retina covers the back of the eye, very thin, and this little patch, this electronic patch, goes on the retina. The patient will wear glasses. There will be some type of camera, like your regular camera that you use for the beautiful vistas here in Iceland, geyser and things like that. And that little camera will take a picture, and electronically the signals will pass to the patch that is on the retina, and that will react in, like with your photographs, pixels, different dots of light, according to the image that is being looked at. For example, a huge geyser coming up, the person might see sparkles going from the camera to the back of the eye. So this has been now tested in a clinical trial in the United States. And since actually I was part of that study for the last 10 years, and they tested many of the patients down the corridor from my office. Wonderful things. Mr. Churchy, blind for 30 years from aggressive retinitis pigmentosa. After 30 years, he could tell the difference between a cup, a knife, and a plate, which for us is nothing. but as I told him, now you don't put your fingers in the potatoes anymore, and you can pick up your knife or your whatever. There was a wonderful study with Professor Sahel in Paris where people now went from total blindness to reading small letters and small words. This is a huge success story. This is, to me, the biggest success story in restoring vision to patients who had no vision at all. I remember Mrs. Churchy sitting in the back watching her husband read letters off of a screen, and she was crying with joy. This doesn't work for everyone. It's only approved for severe retinitis pigmentosa, not for age-related macular degeneration yet. On the other end, with retinitis pigmentosa, there is a very bad form of retinitis pigmentosa called Leber's disease, where basically the child is born blind. And I happen to be the head of the scientific advisory board for this group of people. And at a meeting, we'll have 300 people, and 100 of them will be tiny children, blind, walking around with little white canes or dogs or something. Gene therapy is being tried on those patients with Leber's disease now, with good success.
Is it some kind of gene replacement?
It's gene replacement therapy. So what the patient needs to do with retinitis pigmentosa is to go through and be genotyped to find out what the gene mutation is in their family, for them, their children, mother, dad, something like that. And then the doctor will know what gene to replace through the gene therapy. And again, the good news is that for safety's sake, they did not start testing children. They started testing older patients with Leber's. And most of them, when they're 20 or 30 or 40, have really no vision left, very little vision. But it still would, in a 20 or 30-year-old, helped a little bit and was shown to be safe. They're now treating 3-year-olds, 3 and 4-year-olds with Leber's disease. Successfully, as you said a minute ago, you can, through gene therapy, make a little injection of the proper gene that will go to the photoreceptor cell and get it functional again, get it working. And these patients are, these kids, I've seen a few of them, and I've seen videos of them in mazes where they're walking through, and they are without, prior, there's nothing there, or they're hitting into all the genes, into the chairs or the blocks or whatever. And then a year, 6 months after the gene therapy, they just walk through. So it's miraculous. So again, out of scientific darkness, years and years of basic research, much money, much human effort, many researchers, many doctors. We're getting good examples now for all forms of inherited retinal degeneration. We're getting good examples where we can come to treatments and maybe even cures.
Thank you very much.